Thank you very much for the introduction, Dr. Han. In this session, I'd like to talk about some of the recent progress related to artificial intelligence for pathology, and the title for this session will be Maximizing Insights, Leveraging Artificial Intelligence to Extract Unseen Value from Pathology Slides in GI Cancer. Here's my disclosure. And here I would first cover a new multimodal AI foundation system developed in my lab in the Department of Medical Informatics and Pathology at Harvard Medical School. And this particular system highlights the capability of integrating multi-omics and survival outcome prediction using the standard H&E stand pathology slide. And furthermore, we will cover some clinical application of this AI foundation system and related approaches for enhancing GI cancer evaluation. In the last 3 minutes, I would like to cover a few ongoing challenges in this field and the potential road ahead. So starting with the foundation system. Last fall, our lab published this clinical histopathology imaging evaluation foundation model, or CHIEF model in short, that leveraged thousands of whole slide images to make pathology diagnosis. And we've also been able to predict some previously unknown clinical insights, including their survival outcomes and the treatment response, using the standard H&E pathology slide. And this system is a foundation model. So first of all, what is a foundation model? A foundation model is a large model trained with large and diverse data sets. For example, ChatGPT is a foundation model. It was originally trained using the text information from Wikipedia and other online available sources. But once this model is built, its capability is no longer limited to retrieving information from Wikipedia. Now we can ask ChatGPT to help us plan for our next trip or identify some innovative recipes. Similarly, the research question we have here is, can we leverage similar AI technique to train a pathology foundation model that would be able to help us understand and evaluate this digital pathology slide? So to make this happen, we first collected more than 15 median image patches from publicly available sources, like from the medical literature. And we complement this large data set with additional 60,000 slides we collected at the Dana-Farber Cancer Institute, National Brigham, as well as our collaborators worldwide. And these slides span 19 different anatomical sites. And when we get these pathology samples, we first scan them into whole slide images, or WSIs, and we tile them into manageable patches where we can input them into an image encoder to extract information in a machine understandable format. And another innovative bit about this foundation model is that we also leverage some text information in the accompanying pathology report. And for those text information, we use a text encoder to extract the text embeddings from those information. And here we leverage a similar concept as published in the CLIP model. Is a model released by OpenAI, it's publicly available and open sourced. And the concept of this CLIP model is to align the text embeddings with the image embeddings to maximize the information that we can extract using this joint extraction method to increase the efficiency. And once we extracted these image features, we aggregate the tile level image feature into a sample level, the whole slide level representation. And when we have these whole slide features, we can pipeline into multiple different diagnostic models. For example, we can train a series of diagnostic models to recognize the regions occupied by tumor cells and differentiate between different types and subtypes of cancers. We also use these whole slide level features to predict the molecular profiles of these samples without resorting to standard sequencing techniques. And lastly, we use the same set of features to predict the individual patient's survival outcomes after the standard treatment. So how does this model perform? Here's a quick summary of a very important task on detecting cancer cells from pathology images. And as we can see from this standard receiver operating characteristic curve, where the y-axis plot sensitivity and x-axis plot number 1 minus specificity. So the closer to the upper left corner means that the model has better performance. As we can see from this series of curves, For the detection of colorectal cancer cells, esophageal cancer cells, and many other GI and non-GI cancer types, we have near perfect performance in such tasks using our foundation model. And comparing with many other existing AI approaches in analyzing pathology images, we generally have 15 to 20% improvement in area under the curve, showing that this foundation model system can help us reliably identify important features for pathology diagnosis. Our next task is to see whether we can extend such approach to also identify the origins of cancer. As we know, around 1 to 5% of cancer patients, when they first present to the clinics, their cancers are essentially everywhere. They have distant metastases. And in those cases, it's still important to identify the origin of their cancers because it's related to the optimal treatment. And as we can see from this confusion matrix, on the y-axis, we plotted the true origin identified by molecular testing. On the x-axis, we plotted the predicted origin using only the hemotoxin and eosin stain slide collected at the time of initial diagnosis. And we see a high concordance between our model predicted origin and the true origin later identified through molecular profiling. Especially when we focus on certain selected cases, for example, when the true origin is of colorectal, 97% of the time, our model will be able to identify colorectal as the most likely origin of these cancer cells. And I would also be interested in knowing where are the remaining 3%, that is, when our model makes mistakes, what kind of mistake may they make? So as we can see here, for the remaining 3%, 1% of the time, our model predicted the origin to be related to other GI organs like stomach, esophagus, and many other organs. And for the other 2% of the time, our model predicted the origin could be from other optimal organs. So this shows that our model may be leveraging the similarities between the GI systems and the cancers arising from them in order to identify the origin of cancers. And if we focus on the overall performance, we have more than 99% area under the curve in identifying the origin of cancers across 19 different cancer types. So up to this point, we showcased that this foundation model novel AI system can potentially help pathologists to identify the diagnosis of cancers. And our next research question is, can we leverage similar AI systems to further identify hidden information from standard histopathology images? As an analogy, let's consider this picture, which simply consists of just some random dots and lines. And the challenge to all of us is, can we identify the hidden objects from this particular image? So we might have to squint a little bit, but if I tell you that the painter who created this image intentionally put an animal and a plant inside of this figure, can we identify where they are? So if you look at this image closely, you may be able to identify a dog and a tree inside of this image. And after knowing where they are and their morphology, if you will, going back to the original figure, original image on the left, isn't the contour of these hidden objects more obvious to us? And the analogy here is when we are evaluating these histopathology images using standard approach by reading them under the microscope using expert-driven manual-based evaluation, we also routinely encounter millions of cells and billions of pixels. And can we use AI-based approach to identify the hidden information out of these high-resolution images? For example, can we read out genomic variations directly from this slide? So as we know, this is a task that is impossible for most human evaluators. If you ask me, I can also not be able to predict the genomic variations using only the H&E stain slide. However, here we showcase that our AI-based approach can reliably predict the mutation status of many clinically important genes. The figure panel on the left shows the prediction of prevalent mutations. Here we define as more than 5% of prevalence in our training dataset. As we can see here, for mutations such like GTF2I in thymoma, among many other cancers, we have an area under the curve of more than 91%. Furthermore, if we restrict our analysis to those mutations related to FDA-approved targeted therapies, we see an even higher performance in selected cancer types and selected mutations, such as EZH2 gene in diffuse large B-cell lymphoma, as well as many other different cancer types. So this shows that we can leverage this AI system to identify previously unknown relation between tissue morphology, cell morphology, and their genomic profiles. Lastly, we extended this approach to also predict the patient's overall survival outcomes after the standard treatment. So in this study, we first stratified our samples by their cancer types and cancer stage, because as we know, different cancer types and stage, they generally receive different forms of standard treatments. But even after making this stratification, we still see a wide variety of patient survival outcomes. Some patients would have early recurrence even following the standard treatment. For example, in early stage colorectal cancer, it may involve surgical excision. And here we show that for a series of cancer types, after making this stratification, we can reliably predict the patient with high mortality risk, those in the red group, from those with lower mortality risk in blue. And statistical analysis shows that using the sample we collected at the time of diagnosis, we digitize them, pipe them into this AI method, and we are able to predict their overall survival outcomes after the standard treatment. And here we will also be interested in learning what are the tumor microenvironment our AI system utilize in making such prediction. So here as an example, when we are looking at this pan-cancer analysis, we stratified it by cancer types. And in this example, in lung adenocarcinoma, for those with high mortality risk, our model highlighted regions with granular and solid patterns with regions of necrosis, whereas predicting the lower mortality risk cases, our model focuses attention on the regions with papillary architecture and lower grade nuclear features. So this shows that our data-driven approach can help us systematically identify any particular microenvironments related to our outcomes of interest, and this may help us better identify additional previously unreported tissue morphological signatures related to important clinical outcomes. And this paper is published last fall in the Flagship Journal of Nature, and we have been extending this approach to many different clinical tasks for clinical evaluation. So up to this point, this all seems like nice research work, but how do we make real-world clinical impact by applying such AI assistant in the actual real-world setting? And here I will give you a quick overview of a recent project related to personalized colorectal treatment using AI-enhanced histopathology analysis. In this framework, which we call the multi-omics multi-cohort assessment, we aim to predict both the molecular outcomes and prognostic profiles of colorectal cancer patients. And we obtain our samples from various study cohorts and real-world data sets. This includes the studies led by National Cancer Institute, including the Cancer Genome Atlas, PLCO cancer screening trial, as well as a few cohort studies we collected at Harvard Medical School and School of Public Health. This includes Nurses' Health Study and Health Professional Follow-up Study. So the study populations of these four cohorts are quite different. In addition, because of the laboratory protocols are different, and also we aim to enhance the efficiency in digitizing these samples. So for our internal study cohort we collected in-house, we use tissue microarray rather than whole slide image to reduce the cost for digitizing these samples. And to accommodate this diversity and divergence in their tissue digitization and sample processing profiles, here we use additional approaches to normalize for the color for H&E scan images and for these different digital scans. And we selected the patches most likely contain cancerous tissue using our cancer cell detector. At the end of the day, after we extracted the features, we pipe them into two different but related tasks, one for multi-omics characterization, the other for survival prediction, including overall survival and disease-free survival for colorectal cancer. And for the survival prediction part, we basically connected standard statistical methods for predicting survival without deep learning extracted features. And for the multi-omics part, we use multi-instance learning to capture the typical patterns related to microsatellite instability, as well as many important clinical genomic profiles. And here are our results. For the microsatellite instability prediction, we show that by just looking at the standard H&E slide without resorting to IRC or molecular testing, we have an area under the curve of more than 88% in the TCGA dataset. And we further validated the same approach in our in-house dataset, showing that we can extract additional information from H&E stain that may be useful in predicting their response to immune checkpoint blockade. In addition, we are able to predict a series of copy number alterations, including deletions and amplifications in clinically important genes. We've been successful in predicting the overall survival and disease-free survival for colorectal cancer patients as well. And we show that in the survival-based prediction, our model highlighted regions of the tumor epithelium as well as tumor-infiltrating lymphocyte and stromal tissues in order to make such distinction. And here we developed an explainable AI approach to help us better identify the specific imaging features related to these predictions. In this framework, we first gather our weight map, the attention map, from our end-to-end AI approach, and we further develop a separate multi-label classification model that helps us automatically label 7 important pathology concepts documented in the literature. These include cancer-associated stroma, tumor-infiltrating lymphocytes, and many others. And the results show that we are able to connect this pathology concept with our AI-generated importance weight to better explain our end-to-end AI approach. For example, in the prediction of BRAF mutation, we show that the infiltration of adipose tissue is particularly important in this particular prediction task. Whereas in the BECN1 overexpression prediction model, it highlighted the interactions between smooth muscles and cancerous regions. And this approach can help us better understand what's going on in this large AI model that contains millions to billions of parameters. So here we showcase that this AI approach can be further applied to address many of the ongoing challenges in GI cancer analysis. And what are some ongoing challenges and the potential future directions that the field still need to work on? In the interest of time, here I will only highlight one particular challenge related to the problem of context. The problem of context is not new, and in fact, it was first reported around 50 years ago when the previous generation of AI developers tried to identify a set of systems, a set of rules that may be able to help and guide the behavior of a computational system. They soon realized in their work that it is challenging to identify a set of axioms or assumptions to properly describe the environment for such autonomous system. So what does this all mean in academic terms? Let's forget about these terms and look at a specific real-world example. So here's an image taken from the internet. And the question to all of us is, what is this animal? Is it a tiger or a dog? So on the first glance, the morphology of this particular animal really resembles that of a tiger. However, if we also consider the context, first of all, this is an image coming from the internet. There are a lot of interesting things going on the internet. In addition, there's a particular context on other adjacent objects inside of this image. And once we assemble all this information, we might be able to update our prior and correct our initial mistake. Once we identify our mistake, we joke about it. One user on the internet said, "I was convinced, without a shadow of doubt, that was a tiger." The other said, "With a shadow of doubt, it was a tiger, but without the shadow of doubt, it is a dog." And the third said, "Seems shady." However, when I input this particular image into the state-of-the-art foundation AI system, here are the results I got. This model still believes this particular animal is a tiger without a shadow of doubt. And the particular relevance to GI cancer or pathology evaluation in general is that we also need to handle various concepts and contexts and exceptions in pathology analysis. For example, there are many different artifacts that we need to handle, and those may be related to specific laboratory context. So seeking clinical correlation is always important. And we also need to address around 1 to 2% of this slide come from this FDA-approved scanner that may still contain additional digital scanning artifacts and other arcane scanner errors. And some potential solutions we are developing in our lab, including auto-distribution detection, meaning identify particular samples that may merit additional human-based review. And we also use multi-model learning to incorporate the clinical correlations. And before our model becomes perfect, perhaps it's always helpful to have a human in the loop to double-check our result and avoid our system to autopilot into erroneous diagnosis. In summary, here we have discussed this multi-model foundation AI system for pathology diagnosis, molecular profiling prediction, and prognosis with a particular application to GI cancers. However, multidisciplinary research is still required to further address the technical and implementation challenges. And because of these challenges and these ongoing advances in AI, we are often asked, what's the future of AI in medicine? Well, no one really knows where we are going with these rapid advances in AI in the time frame of months or even weeks that we have new approaches and new revolution every week. Well, the future remains uncertain, but there's one thing that we know with certainty, and that is the best way to predict the future is to create it. And we'd like to invite you to join our journey to create a better future for reliable AI for cancer medicine. Thank you.